guidelines of dyslipidemia and the 2023 Chinese guidelines for lipid management. Here shows the risk aversion flow charts based on risk factors, comorbidities, concomitant conditions, or severe ACV events to develop serum cholesterol stratifications. This is our study design. It's a multi-center randomized double-blind placebo-controlled phase 2 study. The intervention factor was either subcutaneous injection of ACHI 1918 on 4 dosing regimens or placebo. Primary outcomes were the percentage change in LDL levels from baseline. As secondary endpoints include absolute change of baseline in LDL-C and triglycerides, proportions of patients achieving LDL targets, absolute and percentage change of baseline in HDL-C, non-HDL-C, lipoprotein A, ApoB, ApoA1, as well as the safety was also assessed with laboratory tests and by the incidence and severity of adverse events. Here is the study design. Patients with homozygous familial hypercholesterolemia or serum triglyceride over 5.6 millimole per liter were excluded. Those who did not achieve optimal LDL-C on background lipid-lowering medications were screened after obtaining informed consent. After 4 to 8 weeks of running study, the eligible patients were enrolled sequentially into one of 8 dose cohorts at 4:1 ratio. Patients received subcutaneous ACHI 1918 150, 300, or 600 milligram every 4 weeks, or 600 milligram every 8 weeks, alternating with placebo for a total treatment period of the 16 weeks. The extension treatment includes 3 dosing regimen of ACHI 1918 over 36 years, or 600 milligram every 8 weeks, or for over 40 weeks, and then followed for safety. Here is the baseline character of all the participants. The study was conducted in 35 medical centers in China, and 333 patients were enrolled subsequently. At baseline, demographic and clinical characters are generally comparable among the treatment groups. Most patients were at higher risk and receiving steady with the LDL-C levels about 2.8 millimole per liter. And the triglyceridism is also about the 1.8. As illustrated, ACHI 1918 effectively reduced the percentage of LDL-C and triglyceride from baseline among different groups, with higher reduction observed at higher doses. Compared to the placebo, the LDL-C reduction ranged from 21.7 to 29.9, and the triglyceride reduction from 51.7 to 63.2. Of all dosing groups, ACHI 1918 600 milligram every 4 weeks provided the greatest reduction. And accordingly, ACHI 1918 results in a further reduction of absolute LDL-C and triglyceride from baseline by about 1 millimole per liter among these dosing groups respectively. As for ApoB and ApoA1, the absolute reduction from baseline to week 16 was about 0.2 and 0.5 gram per liter respectively. So here shows some other parameters. Etc. 1918 show significant reduction in the percentage of non-HDL-C levels from the baseline. However, there's no significant change in ApoA levels. And notably, achievement of LDL-C targets in ACC 1918 groups were ranged from 59.1 to 71.2 at week 16, significantly higher than that of placebo. Further subgroup analysis found that the greatest LDL-C targets were achieved in patients with moderate to higher and very high ACVD risks. So overall, ACC 1918 demonstrated good safety and tolerability during the 16-week co-treatment period. Most treatment-related adverse events were mild, with no significant safety concerns identified. Both TEAE and TRAE in more than 2% of patients were comparable between the two groups. Also, the injection site reaction was infrequent, about 3.4%, primarily presenting as mild pain and erythema. So I will hear to conclusion. ACC 1918 significantly reduced the LDL-C and triglyceride levels, showing favorable lipid lowering efficiency in moderate or higher risk of ACVD patients, supporting ACC 1918 as a potential therapeutic option for hyperlipidemia, standard lipid lowering treatment. Our extension study is now near the end of the follow-up, maybe in next month, and then we are looking forward to get the news and share with all our colleagues. So finally, we have acknowledgement. Thanks all the participants and their families, all investigators and research personnel, and also all of our sponsors. So we're truly honored to have our research public in the JACC in last month. Thank you, Professor Yao.
Thank you, Dr. Xie. Very nice presentation. So this, on the screen with us, we have Dr. Low as well and Dr. Xie. I guess we can have a short discussion on this particular study first before we go to Dr. Low's presentation. So maybe I'll just start off with a question. For this phase 2 study, my sense of the data suggests that there is no major safety signal, but could you bring up your slides on the adverse effects again? I'd like to ask a few questions on that.
Sure.
So there was no real difference between if you could go to the adverse effects, please, the adverse events.
Yeah.
Yes. So there was one death in this cohort. Do you have any details on this particular case?
So all the participants in our trials was the moderate to higher risk of ACVD. So some patients will have the evidence of atherosclerosis. So all patients have the injection of the antibody. So we find some TAE, the treatment emergent adverse events. So that was most mild, some mild pain in the injection site, and there's no severe adverse events have been found in this study. And all patients have the good tolerability. So now we have all the patients in our extension study. Yeah.
Okay. I think the usual way that these adverse effects are recorded is that if as long as there are any adverse effects
Yeah.
happening after the initiation of the study, it will be recorded. And the key thing is to look for any signal that suggests an excess of such risk. And in this case, the numbers of adverse effects are very low, suggesting that this drug has a good safety profile. Wan Jia, do you have any questions for Dr. Xie?
Thank you, Dr. Xie, for a great presentation. I want to ask you about this side effect. So there were reported 6 people who had a raised liver enzyme in your treatment arm group. And then, do you find that to be significant? And what is the postulation with, the ANGPTL3 monoclonal antibody? The ALT increased. The next slide.
You could go to your next slide.
Hold on. Yeah.
This one, yeah.
Yeah. The ALT increase. Do you think it's related or?
We have compared it to groups, so maybe some patients also have the just have the ALT elevation before enrolling our study. So we have the less than 2-fold of the ALT elevations. So that I think that was because due to the hyperlipidemia. So, however, we have a statistic and there's no significance between the 2 groups. Yeah. So I think that the antibody was safety. Yeah.
Okay, thank you.
Thank you.
So in your plans for looking at this mechanism for the longer term results, have you all started a study for phase 3 study?
Yeah, we have reported to our FDA, I mean in China. So we hope to to start our phase 2 study as soon as possible. So we are on schedule.
Right. And from this phase 2 study, are you able to share which dose will you all choose for the phase 3 study?
Okay, so in this phase 2 study, we have the different doses like these 4, and significant reduction was found in the 600 milligram every 4 weeks. So we have the we schedule in our phase 3. We will choose this regimen. Yeah.
Yes. Okay. So I think that's the one of the most efficacious dose. Can I maybe just ask one more question? The study was conducted in China only, right? Do you think that there is an impact from a race or ethnicity point of view that that the drug studies on the drug may need to be replicated in more diverse populations?
Yeah, that's a good idea. And I think we can have the older patient, maybe in our Asia patients will be participate in this study. So that will give us more stronger evidence for the older population.
Yes, I think I think of this is very favorable and promising results. But I do think that the phase 3 studies will shed further insights into the tolerability as well as the efficacy of this drug, and also if it can be extended to other populations outside the largely Chinese population. I think that would be very helpful. Maybe if Wan Jia doesn't have any other questions, I will just ask one more question. This is an injectable, and we already have several injectables in the market. The evolocumab, alirocumab, and the inclisiran, and there's a whole pantheon of new agents coming on board, which are all injectables from the RNA therapeutics arena. How do you think, as a whole, how do you think we can strategize which agent to use first? Do you have any thoughts? And I recognize that there are no head-to-head comparisons of these new novel therapies, but do you have any insights as to how we might approach the use of injectables in the future?
Thank you for the question. So I know the Chinese population is a large population. So we almost 80 to 90% was round in our hand, and also have the some rare visited in the northwest of China. So because as you mentioned, we have the statin and cholesterol absorption. Inhibitor also have some injection agents as the inclisiran, as the PCSK9 inhibitor. So I can recommend different agents for different patients, such as the patient, he have the elevated in LDL-C or triglycerides, especially in the patients with diabetes, we might have the lower birth of the lipid. So we would recommend the ACC-1918 in the near future. And also, if the patients cannot reach the optimal target of LDL-C, at the moment, we have the inclisiran and PCSK9 agents for our patients in clinical practice. So I think the more agents we can use, the more achievement of the lipid targets will be achieved for the patients.
Can I ask a question, Dr. Xie? So the other competitor would be the evinacumab, so the ANGPTL3 monoclonal inhibitor, but that one is infusion. Whereas, am I right that the one that you're studying is a subcutaneous injection? Any other differences with evinacumab?
Yeah, so the evinacumab cannot be available in Chinese clinical practice, and
same for us.
Yeah. So ACC-1918 have modified the structure of the antibody, so it can have the long half time for the agents. So patients will be injected for every 4 weeks to 8 weeks, and it can be achieved the same clinical efficacy. So maybe the different molecule structure, the different pharma kinase in the patients, and that can be more available or tolerable, can be increased our comparable for patients to have the lipid lowering therapy. Yeah.
Thanks very much. I think it is a good time to go to Dr. Lo's presentation, and please stay on with us, Dr. Xie, because we'll like your insights as we have the discussion on Dr. Lo's talk. And Wanjia, if you are sharing your slides, maybe just to give a quick introduction, Dr. Lo is from the Changi General Hospital in Singapore, and she's going to share with us her insights or takeaways from the alpaca phase 2 trial on lipodisiran with up to 540 days follow-up. Wanjia, please.
Thank you for the introduction. Thank you for staying on, or when you're watching it from your home. I hope you are interested to learn about LPA. So this is a great opportunity to discuss a new trial medication that just published 1 month ago. It is a lipodisiran LPA lowering drug called alpaca phase 2 trial. So this was presented at the ACC, but I didn't attend that. So And I'm not part of the study, nor have I received anything from Eli Lee, and which is a good thing, because then I can give you my opinion of this great study. So lepodisiran, a long duration small interfering RNA targeting LPA, lowers LPA significantly up to 95%. It's a 6-monthly injection. This is a study by the APACA trial investigators and is written by Professor Nissen et al. So LPA is a major problem around the world. It affects at least, 1 billion people, because if you take the cutoff of 50 milligram per deciliter or 125 nanomole per liter, that will have an implication to 20% of the world population. This prevalence chain is different among different ethnicity. So among the Blacks, it could be as high as 30%, and Chinese can be around 5 to 10%. So it does vary depending on the ethnicity. LPA is a very special molecule. It's very important to remember that it is not the same as LDL. However, LPA has an LDL-like lipid core, and it carries 1 ApoB per particle, similar to LDL. The difference to LPA between LPA and LDL is the additional apolityl-A chain, hence the name Lp(a). Apolityl-A chain can have variable length. Because of the Kringle 4 type 2 here, it can be very short or very long, and that's why the size can be very different, which is also why nowadays all the guidelines recommend to report in nanomoles, which is a particular number, rather than in mass. So LPA itself is pro-inflammatory, pro-calcific, and pro-thrombotic. This makes it per particle, compared with LDL, more likely to cause heart attack, stroke, and also it has a special special cause association with calcific aortic valve stenosis. So lepodisiran. Lepodisiran is an siRNA, which is targeting the liver. And because it is siRNA therapy and actually does not have any off-target effect, because it goes into the liver to reduce the production of apolityl-A. So apolityl-A is produced from the binding of ApoA plus ApoB. A rate-limiting step in the process is a transcription of LPA gene to make a messenger RNA, which will then become a protein. So RNA interference therapy, which is like siRNA or antisense oligonucleotide, tries to block this production. So they will shoot the messenger RNA, and then, as you see in this picture here, once siRNA goes into the liver, it binds to, which is via the ASGR receptor, you go into the RISC loading complex. RISC loading complex are natural complexes that we have in our liver to break down unwanted RNA messengers, RNA, so that it doesn't get translated. Then from there, all the target mRNAs come on, and it's actually truncated before it can become protein. And what's really amazing is the progression of the siRNA therapy in multiple parts of the medical field. Is not just in lipidology, but also in eye and skin, and also in cancer therapy. And they can do that because if they can tag onto a protein, the medication can go to specific organs and don't cause off-target effects. So let's talk about lepodisiran phase 1 trial before we talk about the current study of phase 2 trial. So the phase 1 trial was 48 patients with a little bit of elevated LPA of 75 nanomole per liter, roughly about 30 milligram per deciliter. And with higher dosing, you can see that it lowers LPA almost down to nothing. So with minus, that is 96% with a 300 milligram dose, and minus 97% with a 608 milligram dose. So the effect can last so long that practically 1 year after one dose, you can see very low LPA. This led to the phase 2 lepodisiran trial called APACA. So at first, they had run the screen through 320, they were aimed to go through 320 people around with 66 centers recruiting from in the year 2022, and the study ended in 2024. The randomization method was 2 placebo to 1 lepodisiran, the lowest dose 60 milligram, and the rest was 2 ratios, so 2 for 96 milligram, 400 milligram, and again, lepodisiran 400 milligram. The difference between the final 2 columns here is that one is 400 milligrams of lepodisiran at baseline, followed by day 180, a placebo. The second group here, The final group is 400 milligrams at baseline and 400 milligrams at day 180. Inclusion criteria were 40 years and above, LPA at least 175 nanomole per liter. This is used uniformly by the Randolph assay, and all participants had to have stable doses of lipid medication for at least 4 weeks. They purposely excluded people who were of childbearing age and women, had recent CVD within 3 months, already have moderate or severe heart failure, has a severe kidney failure, GFR less than 30, or have hepatic enzymes of more than 3 times upper limit. So the APACA trial was successful in recruiting, and they had 320 people, the mean age of 62 years old, 57% were men. This was mostly white ethnicity, 80% were Caucasian, BMI 27, and 70% were on statins. 68% were considered high cardiovascular risk, and 48% already had known CAD, and 30% had AMI before. So although the gender-wise, they were quite, uniformly distributed, almost half is male and female, but as I said, it was predominantly a white ethnicity. And interestingly, we also had about 14% of Asians in the placebo arm and 8 to 20% in the various groups of the lepodisiran. So here are the characteristics. So the median LPA for the entire group were 253.9 nanomole per liter. So 250, which is very high. The median LDL was about 1.97 to 2 millimole per liter. The median ApoB was around 1.1 millimole per liter, and 74% were statin. So that's why the LDL were quite good for most people. The primary endpoint was to look at the placebo-adjusted time average percentage change from baseline in the LPA concentration from day 60 to day 180. And that was amazing. We see that even at the lowest dose of 16 milligram, that was a 40.8% drop of LPA. And then in the 96 milligram dose, it was 75% drop. In the 400 milligram dose at baseline only, it was already a 93.9% LPA drop. Here is a very nice figure that showed that the higher the dose, the more the LPA lowering. The yellow line here is of interest. So we call it the pooled arm because it has the group that has 400 milligrams of injection at baseline. And then you see that it drops down to 93.5%. After that, it splits into the purple line. Is if after they receive placebo arm, it does creep up. It doesn't go back to baseline yet at the 540 days, so practically, almost 1.5 years later. So you see that it is about 60% reduction there. But if the group had continued to have a 400 milligram dosing at the day 180, then LPA remained to be very, very low, with a total minus 95% reduction. Also, they looked at ApoB as a secondary endpoint, and ApoB was lowered by 15.5% with the lepodisiran 4 milligram dose. Here is a waterfall plot showing the effects in the placebo group, where you see that there are some people that have raised LPA by even up to 50%. Majority were, plus or minus 10-20%, and some people did have lowering LPA even with the placebo. That just shows that LPA is mostly genetic, but there's still a component of variability of 10 to 30% in anyone. The other group, where has 400 milligram lepodisiran, most people had amazing LPA lowering. A minority here actually had 40 or 50% LPA lowering. So this is what everyone always wants to know, is there any side effect? So it is amazing to see that there's a very favorable safety profile. There was no serious adverse event, generally only a mild dose-dependent injection site reactions of 0 to 12% over here. And there was no withdrawal on treatment arm. So we've discussed the ALPACA trial, which is siRNA called lepodisiran. It's a 6-monthly injection, and And what's really amazing is that it's the longest duration of action of LPA lowering with hardly any side effects. 400 milligram dose appears to lower LPA by 88 to 90+%, even at 1 year. So that's really quite long lasting. Because it's so long lasting, the authors also did point out that this could also potentially be a problem because it's such prolonged duration of action, and therefore more studies, longer acting ones, are required. For now, this trial only had maximum 2 doses, so we don't know if there was multiple more doses over long term. Is there going to be a problem? Is there any build of antibodies and so forth? So we look forward to the phase 3 trial, which is called ACCLAIM, which is currently ongoing, recruiting patients who have high LPA. This is a CVOT trial. The limitations of the current APACA trial that the authors feel was most important was there was very few Black participants. This is important because actually the Black populations has the highest prevalence of LPA among all other ethnicities. Just want to go through a few other studies that are looking into LPA lowering besides lepodisiran. Pelacarsen is a study by Novartis, and the cardiovascular outcome trial is the Horizon trial, currently ongoing. It aimed to recruit 7,000 people with CVD and a high LPA of at least 117 nanomolar. We know that the phase 2 trial of 286 people actually showed that it lowered LPA down to 80% with hardly any side effect. So we look forward to this readout, which is projected to be sometime at the end of this year. This is a monthly injection. Also, we look forward to Olpasiran trial. This is called Ocean A, which is sponsored by Amgen. And the phase 2 trial was also very promising. As you see, it lowered almost like the line is at 100%, but I mean, it's 90 something percent of LPA lowering. And this is an siRNA, which is similar to what lepodisiran is. So they're both siRNAs. So for Olpasiran, they are aiming to recruit 6,000 people. And I think they have done that, and it's ongoing now in people who have high LPA, more than 200 nanomole. It's an injection of every 12 weeks. Here is a slide that I've compiled to sort of summarize there are different therapies that potentially can lower LPA. I do not mean that they are licensed to lower LPA, but they have effects on LPA. So let's divide it by the percentage of lowering effect. Looking first at no effect or plus minus 10 to 20%. Statins may potentially increase LPA in some people by 10 to 20%. We do not know why, and this may be something to do with their genes. Then there's also CETP inhibitors, the older ones that are not in clinical practice. They have been shown to lower by 10%. Diet and exercise is important also. They do have some variability in LPA. And of course, excessive weight will tend to increase all lipid profile and a little bit of LPA too. Aspirin has been shown in some small studies that it can lower LPA by 10 to 20%. And what about a bigger amount with 20 to 30% is more clinically significant? Niacin can actually do that, but the problem with niacin is it has so much side effect that we hardly use anymore. PCSK9 inhibitors also do that, and the post-hoc analysis in the FOREO and Odyssey trial show that it does lower LPA by 30%. And there are CETP inhibitors which increase HDL, but they also surprisingly lower LPA by 20 to 50%. Mipolmersen and resmetirom, which both works in the liver, one is against ApoB and one is for fatty liver, they seem to also have LPA lowering effect by 20 to 40%. But lowering at least 30% would be more important for people who already have ASCVD, and the biggest data really comes from LPA apheresis, which is dialysis for LPA. This we do not do in Singapore, but some countries, they have funding to do that, and that can lower LPA. And also what we look forward to and what we've discussed today is the antisense oligonucleotide, pelacarsen, siRNA, olpasiran, lepodisiran, zilasiran, and also an oral inhibitor for LPA called muvalaplin. All this will really shape the future LPA in the coming years. Okay. So I think that regardless of those trials coming out or not, I think it's time to be more aware. And just wanted to show LPA Awareness Day, the Singapore inaugural one that I hosted last year. It went very well. We had multiple talks and people and games, and it was attended by 600 plus people in person. That gives me some courage to continue to do some better work this year and the last year through collaboration with many people, including Dr. Yo, KK, and National Heart Center. We have done multiple in creating awareness. But this week is a very special week. I created this CG Changi General Hospital Lipid and LPA Awareness Week, where on the 22nd of April, doctors and nurses, a hybrid event, we had about 700 people online and a few hundred in person that we went through LDL, triglyceride, LPA. And then we had an in-person event with a lot of patients and public and patient sharing, telling about their story about LPA, which was very touching. And then we also had a webinar with the National Library. And today is an amazing day to discuss about new trials in LPA to give hope to all of us about this very common condition affecting 20% of the world. And we have even more upcoming LPA awareness. This is a picture from 2 days ago, and I was really proud that this event was recognized by also APCMC and also National Heart Center, as well as Singapore Heart Foundation and the Familial Hypercholesterolemia Europe Foundation, FHEH. And I thought that since we have a little bit of time, I could actually show a video, which is only about one minute long. Okay.
LILAC summarizes 5 salient points that we need to consider in managing LPA. L stands for LPA is a cardiovascular risk enhancer. So use this to improve the risk prediction of a cardiovascular disease for a patient. I is improve control of all modifiable cardiovascular risk factor. This is the first actionable strategy that one can do. And the second actionable strategy that you can discuss with a patient is L for lower LDL and ideally lower LPA concentrations. Discuss with your patient on the appropriate LDL goals depending on their predicted cardiovascular risk. Someone who has very high LPA may need LPA lowering treatment. A stands for assess for conditions related to elevated LPA, including aortic valve stenosis, and consider aspirin when there is significant burden of atherosclerosis. And C is cascade testing for LPA, if the index case is very high LPA.
Yes. So this video just is to highlight, about the concepts that, we can do already to manage patient high LPA, even though we haven't got those fancy long duration LPA lowering drugs yet. And basically just try to lower the LDL, try to mitigate all the cardiovascular risk factors. And if you like LILAC, you can also scan the QR code to read more. Or you can scan these YouTube links that I've created to educate the junior doctors and general physicians and physicians.
To help the busy clinician and allied healthcare to manage this important and common cardiovascular risk factor. Here are the principles of LILAC which can be used for LPA as well as LDL. Firstly, for L, think of the risk of what this lipid can cause. I refers to improved lifestyle and L is to lower risk factor. So I and L refers to what the patient should do right now and how doctors can facilitate that. A is what doctors need to assess for, and C is to consider cascade testing or at least promote awareness among family members.
Okay. And if you want to learn more about essays, it's also in my interview. You can scan here, or you can also read my book, which is on Amazon. And with that, I end my talk, and I'm happy to discuss more about the trials. Dr. Yu.
Thank you very much, Mancia. Very nice summary of the alpaca trial and an overview of the other agents available. Doctors here and I'm not sure whether Dr. Lin is around as well. If you have any questions, please chime in. But maybe I'll just start off with a first question for Dr. Loh. Dr. Loh, can you just 2 points. One is first, in the alpaca study, remind us what was the treatment, or rather the study inclusion criteria in terms of patients. Who did they include in the study?
Okay. So they were looking for adults of 40 years and above with LPA at least 175 nanomole per liter. So that's roughly about 70 milligrams per deciliter, and already on stable medications. So they were aiming for people who have a slightly higher risk. That's why 48% were already had known CAD, 68% were already had very high CV risk, and even a third had an AMI.
So they did not. They were not looking for patients. They were not targeting established CVD patients, but it so happened that about half already had known
Yes.
CVD. I see. My second question relates to the genetics of Lp(a). Because you mentioned cascade testing, could you share with us what is the genetic transmission for Lp(a)? What kind of cascade testing has been studied in the global literature?
So that's an excellent question. So cascade testing just means that we are testing in the family members, starting with the first degree family members. So it's actually similar to familial hypercholesterolemia, where we know that there's a 50% transmission. But because FH is an autosomal condition where it's actually due to a single genetic mutation, could be missense or nonsense or what, so forth. So it's actually much easier to do genetic testing. But when you're doing DNA testing. But for LPA, it's not really one genetic point of mutation. So in fact, it's more, you can call it sort of a polygenic kind of effect where the majority is still the LPA gene. So we actually call it autosomal codomain effect. So it depends on what let's say the index case have, and then the spouse, and then also then the children can have a mixture of LPA levels. The good thing about LPA is you do not need DNA testing. So this is just a blood test for LPA level. It is better than doing DNA testing because there's actually no clear genetic test that will define that you have or will not have high LPA. Then in terms of the level of sending it down per generations is 50%, 1 in 2. Studies in Australia particularly have shown that that it is a 1 in 2 transmission, so 50%. So 50% transmission if you have LPA of at least 120, but of course LPA is higher, that's more likely that you will pass it down. So in terms of cascade testing in clinical practice, what is a practical point of doing it, way of doing it? We do not call families ourselves. It's best to let the patient that you're seeing know that they should spread awareness among their family that they have very high LPA and that may have affected their heart or stroke or so forth, and that they could help to get their family to be tested early so that they can start some strategies to avoid themselves having a heart attack and stroke. And LILAC is just a simple way to remember a few steps of how you could do it. But the most important part is, is to make sure you try to improve all your overall cardiovascular risk factors. You may not actually need to start on treatment yet unless you're very high cardiovascular risk.
Thank you. Dr. Xie, do you have questions for Dr. Loh?
Thank you, Professor Yeo. So I'm still interested with the lipo-A. So, in China, we also trying to find some sub-fractions of the LDL-C or HDL-C or some in lipo profile. So as you have mentioned, lipo-A maybe have a genetic, and you also, the participants was about less than 20% were from Asia. So except for the diet or the life style. So how's the important effect to elevated lipo-A? lipo-A. And another question, there have some agents like the many series, targeting the PCSK9, targeting lipo-A, maybe targeting the ApoA also. So do you think in the near future, the lipo-A as a stronger inducer for atherosclerosis maybe can replace all of the PCSK9 inhibitors? So how to recommend to our patients in our clinical trial?
I see. Okay.
Yeah.
Yes. So there's a two-part question. Thank you, Dr. Xie. So the first one is actually, I will always tell patients the first thing they do is really control diet, exercise, don't smoke, and then control obesity, because although it doesn't lower LPA greatly, maybe at best 10-20%, when they get a healthier diet. The truth is that it really lowered the overall cardiovascular risk greatly. So, and because LPA, we're talking about accumulative LPA for a long time. And if they start healthy eating and all these good behaviors from a young age, it can really protect them for a long time, especially smoking. Smoking is very bad when it's together with LPA. So then the second part, which is really important, is also a follow-up to what Dr. Yeo mentioned in the beginning about how there's so many injectables, which going to come first, we can lower TG and LDL and LPA. I think it will be individualized to the patient depending on what is the biggest problem there. The good thing about the PCSK9 inhibitor as well as LPA lowering drugs is that they both actually lower each LDL and LPA. But PCSK9 inhibitors, including inclisiran, actually they will lower LDL more, 50-70%. They lower LPA a little bit, 20-30%. Generally, but of course, every human is a bit different. Some lower more and later. Then the LPA lowering drugs actually seem to have a signal of the opposite, where they actually have LPA lowering by 70-90%, and then it lowers LDL also a little bit by 10-20%. So it's really amazing. And I think that when it comes out, it will be a battle of the cost and a battle of how many injections and availability. And I don't know whether or not we will have any consensus in the Asians about what should go first. But lowering triglyceride, like you mentioned in your amazing study, where you have monoclonal antibodies every month, that lowers LDL and TG, that should also have a place in it. But the question is, what target and which go first? Yeah, I think we need trials. Maybe we can work together to see which trials at what pace and who should do, when we should do what. Yeah.
So it's amazing work you have shown us. Thank you.
Okay, but I'm not involved in alpaca trial, just want to say. So you have the amazing work. Congratulations on your JACC paper.
Thank you.
Yeah, I think the science for this is really evolving at a tremendous speed, and I can barely pronounce all the trial names and the drug names. So I think it's a challenge to keep abreast of the developments, but it is for that reason we have webinars like this to help all of us track these studies. I have an additional question on Lp(a), and that is the studies show the relationship with aortic stenosis, and Wanxia, you mentioned that in your introduction as well. Could you shed a little bit more light as to the pathogenesis, why the aortic valve and why aortic stenosis?
So, there was this amazing study published last year. So it's like a Mendelian randomization one, where they actually look at LPA particle and also LDL, and they can actually make this inference from the quantity of ApoB that is being carried, and what is the likelihood of LPA versus LDL, which one is likelihood to be more pathogenic. Actually, one LPA is about 6 times more pathogenic than an LDL particle. But the good news is we have many more LDL than LPA. LDL tend to be millimoles, whereas LPA is nanomoles. And so why is LPA like that? So this is what a picture on the right show, that not only it actually carries cholesterol and carries oxidized phospholipid, but it also tend to be more inflammatory and promotes calcification through, NF-kappa B, IL-6, and also it decrease clot permeability, increase platelet, more clotting and things like that. So this is proposed to be the reason why LPA actually tend to be associated with calcific aortic valve stenosis. In fact, it's the only genetic cause for aortic stenosis. But it is still tends to be a bit older age rather than, in the 20s or 30s. So it still takes time for it to happen. We are lacking data for calcific aortic valve stenosis in Asians. I know the Koreans did publish something recently, but I think we still need more data around in Asia about this and what to do. And also we're waiting for some trials. One of them are specifically looking at aortic valve stenosis and LPA lowering. So we'll see if that actually improves.
Right. And you had mentioned cascade screening. At what age would you consider recommend in family if if an index patient had been identified as having elevated Lp(a), at what age do you recommend or particular recommend screening their children or first degree of relatives? Of course, the older folks, maybe which of the younger folks?
I think in terms of age, at least when they're adult already, so that could be 21 or that could be 18 when they're ready to be tested. It is a lifelong accumulation thing, so having it high for 1 or 2 years not a big deal, but having Lpa high for a few decades may be a big deal. So there are papers in pediatrics who have actually shown that there's a slight increased risk of stroke in the kids, but generally for most people, we're still talking about Lpa is a major risk factor for people in the middle age and above, unless they have multiple risk factors along with Lpa. So smoking is one of them, high blood pressure, uncontrolled diabetes, and so forth. Then they are at risk of having stroke and heart attack, is much higher, and they can have that in the 20s. So I have patients in my clinic who are 20 years old having heart attack, because actually they had other reasons along with the high Lpa. It also depends on how high the Lpa is. If the Lpa is as high as 500 or even 600 nanomoles, which I have in my clinic, then I am a bit worried. I wouldn't say you should cascade at 30, but what I think you should do, offer your kids when they are old enough to be tested, as they are willing to be tested, and that could be, 16 or 18 or 21. But generally, I feel that we should not stress people in their childhood, I find it stressful myself as a mother. So I would wait till they're a little bit older. Yeah.
Thank you for sharing those thoughts. Dr. Xie, do you have any questions? Any other questions?
No, thank you.
Okay. So maybe, sorry, Wan Xia, to put you on the spot again, one more question. You mentioned aspirin.
Yes.
And is it why aspirin? What about the other antiplatelet agents?
I think
Is there data?
Yeah, so it's really interesting. Maybe because aspirin itself is anti-inflammatory, and then we know the Lpa is pro-inflammatory. Maybe that's why it worked. But actually, this observation already came more than 10 years ago, that they found that actually aspirin reduced the Lpa a little bit. It was in the Asian study as well, also as in women's study, but they were not specifically looking for Lpa lowering, so we can't make big comments about that. But also the recent major major reanalysis of a trial called ASPRI study. So this is a aspirin, which uses primary prevention cohort. So then they follow longitudinally over decades. You see, do they increase risk of stroke? And aspirin was found that, if we didn't know the Lpa, it didn't actually it reduced the risk of stroke in the ASPRI trial. But when they reanalyzed that and published that a few years ago, then they showed that, the people who were actually had high likelihood to have high Lpa, they did that by genetic genotyping, and then they were the one that actually had less likelihood to get stroke. So that's one of the examples of the trials that show that, actually, aspirin did protect people with high Lpa, but doesn't protect just everybody, but who had a higher kind of inflammatory status, I suppose, high Lpa.
Thank you very much. So I think this is a good time to bring the webinar to a close. I'd like to thank our two speakers, Dr. Xie from the second affiliated hospital at Zhejiang University, for her presentation that she had already done at ACC on the angiopoietin-like 3 monoclonal antibody treatment in a phase 2 study. And Dr. Low Wan Xia, who gave a review of the Alpaca phase 2 study with up to 540 days follow-up, which is a siRNA therapy for lipoprotein(a), and the sharing that she provided on some of the outreach programs that she has started in Singapore. So with that, I'd also like to thank the Taiwan Heart Foundation and the Asian Pacific Society of Cardiology and the Asia Pacific Cardiometabolic Consortium for hosting today's session. I have learned a lot from listening to our two speakers, and I hope you have too as well. So with that, thank you very much. I'd like to close the session and wish you all a happy weekend ahead. Thank you.
Thank you.